remains the cornerstone of breast cancer control. When the disease is detected early and if adequate diagnosis and treatment are available, there is a good chance that breast cancer can be cured. If detected late, however, curative treatment is often no longer an option. The month of October is considered the Breast Cancer Awareness Month, but breast cancer awareness is not just a month, as the popular slogan goes. It is a necessary conversation which we aim to take forward through the medium of this webinar. Also, due to the current pandemic situation, the world is not able to focus on some other issues which have been prevalent since years, which formed which further increases the need to talk about them. We seek to learn and help others learn more about the relatively untapped topic of breast cancer. Our aim is to explore more about its causes, symptoms, and treatment. Women generally hesitate to talk about breast cancer. Due to this, they do not come up with the symptoms they might be facing, and though they do not take the proper treatment. This increases the morbidity rate, and we fail to fight the disease, irrespective of one's gender. Our association with breast cancer awareness is not only limited to spreading awareness. It is a long journey, and this webinar is just a part of it. We will be conducting a set of programs to aware women around us to empower them for having a conversation about it. It would include talking to them about the symptoms, causes, and ways to recover or when to go to a doctor. Not only women, but men's participation for the cause would rather increase the reach of awareness levels among people. To carry forward this idea of engaging with people, we have launched our own hashtag Let That Pink In, through our social media campaign. We request you all to support the cause by promoting the hashtag. We've prepared a video to showcase the same. I would now request Devashish to please share the screen and play the video for all of us.
Hey, I have something to tell and it's kind of an emergency.
क्या हुआ?
I think, nahi. Actually, I have been diagnosed with breast cancer.
But you're a boy and boys don't have breast cancer.
Spoiler alert, we all have breast tissues. Look, I'm serious, okay?
He looks kind of sus.
What's with the what's up outdoor attitude? I'm telling you something which is real and prevalent in society. एक तो awareness खुद चल के तुम्हारे पास आ रही है and you're choosing to ignore it.
Okay, I understand boys have tissues, but they're not big enough to have tumor.
Are you even listening to me since then?
Okay, it's all gibberish to me. It doesn't make sense.
I guess I will have to get them here now.
Oh.
Me, कौन?
Pink October is a collaborated effort between NSS and gender champions for spreading awareness about breast cancer.
Well, I'm also here to shun the myths that are prevalent in the society and to replace them with actual facts.
So, you are saying that even I can develop breast cancer?
Definitely. But even if we could not, that should not stop us from spreading awareness about this to our mothers and sisters, or in fact to every other gender who is prone to this.
Wow. I like that thinking.
No, bro. Let that Pinky.
With this thought in mind, we would like to extend an invitation to Dr. Shilpa Khatri-Babur, Professor and Director, Academic Excellence and Public Relation and Protocol of WIPS, and Faculty Convener for NSS WIPS and Gender Champions, to present the welcome address. Ma'am is a sociologist from Delhi School of Economics who has been imparting knowledge for the past 25 years. A strong believer of the critical pedagogy, she holds several national as well as international publications and works closely with NGOs as a crusader against drug abuse amongst the youth. Ma'am, the floor is all yours.
Thank you so much, Prableen, and thank you, everybody. I'm really humbled by this introduction. I've always believed and said my introduction is my students, and you make me so proud with this particular initiative. On behalf of Vivekananda Institute of Professional Studies, I extend a very pink welcome to all of you. We are very privileged to have amongst us highly promising trio of doctors, a profession which has always been revered as God personified. So I would first, want all of you to express our gratitude with folded hands to all of them. Thank you very much, doctors, for being with us. The first one to go amongst the trio is Dr. Vikas Talreja. We have a video by him, which is going to be followed by question answers somewhere around 5:45. Dr. Vikas Talreja is a postgraduate cardiology from Johns Hopkins University. He's the recipient of the International Association for the Study of Lung Cancer Mentorship Award. Dr. Talreja is European certified medical oncologist and is currently a consultant at the Specialist Department of Medical Oncology and Hematology at Regency Hospital, Kanpur. So we welcome you, Dr. Vikas Talreja. It's a privilege to have you with us. Thank you. Thank you so much for sharing those lovely flowers, and we mean it from the bottom of our heart. Over to you, Omisha. You are on mute, Bacha.
So sorry. We now have an informative video from Dr. Vikas Talreja. I would request Devashish to kindly share his screen and enlighten the audience with that video.
A very good evening to everybody. Today we are discussing the breast cancer and the various aspects of the breast cancer. I myself is Dr. Vikas Talreja. I am a DM medical oncologist. The medical oncologist is a cancer specialist who deals specially with all forms of cancers and their medicines. So all forms of chemotherapies, targeted therapies, and other form of treatments of cancer are we are the specialist of that. And I was formerly employed at Tata Hospital and Safdarjung Hospital. Currently, I am employed at Regency Hospital, Kanpur. So when we deal with the breast cancer, we need to know what are the various screening tools for the breast cancer diagnosis. How do you define as what is clinical breast examination, self-examination, mammography, ultrasonography, FNAC, cytology? And why is breast cancer that much importance? So as you could see, the yellow line that indicates the breast cancer has shown the maximum rise of the cases from being 1970 being 20.1 per 1 lakh females to 31.3 in 2000. The incidence has risen quite sharply. And similarly, one of the most common causes in Indian also, the most common cause of the cancer is the breast cancer. And it is the most common cancer in women worldwide. Most common cause of death from cancer among the women. More than 3/4 of these women in developing countries are diagnosed in advanced stage of disease. That is in a stage 3 or a 4 disease. And if these lesions are detected, most breast cancers can be effectively treated with good outcomes. In India, 1,44,937 women were newly detected with breast cancer in 2012, of which 70,218 women died. So for roughly every 2 women newly diagnosed with breast cancer, 1 dies of this disease. And that's a very sad prognosis. And that's why we need to see which women we need to screen. So all women between the ages of 40 to 60 years of age needs to be screened. All women identified with the breast mass that has previously not been clinically evaluated needs to be screened for the breast cancer. Women with high risk factors can be offered screening from age 30 years. So what are those high risk factors? There is no children or children after 30 years of age. The mother or sister had a breast cancer. There was history of prior breast cancer, or there was history of breast biopsies inconclusive of witches, and initiation of menses before 12 years of age, and an overweight status. And the screening has to be done every 2 years. So when we examine, we need to be very sensitive because it's a sensitive part of a woman, and therefore we need to first of all talk her into an examination. We have to respect that the woman's sense of privacy is there and the woman is anxious. We have to assure that it is just for diagnosis purpose, and we are here to make her comfortable. Throughout the examination approach, we should be very gentle in our approach and should avoid any sudden and unexpected movements, and perform each step gently and ask her if she's having any discomfort during any part of the examination. And we can also assess her by the facial expressions she has. We always have to take into factor the cultural factors and deciding what clothing we have to remove or what clothing we have to keep for her. And we have to cover the non-examined breast with a clean sheet or a drape. These examinations should be performed in a clean, well-lit private examination or a procedure room that has a source of clean water. And we always insist that a female assistant should be available to accompany the woman when a male clinician is examining. One of the most common cancer, and that's why it tends to have a number of myths. So I would tend in next couple of slides, I will tend to find out what's the myth associated with these cancers and what's the real fact. So most common myth is that the most breast cancers runs in the families, while the reality is only 5 to 10% of them are the hereditary. There are basically 90% of them which are largely due to lifestyle and environmental factors. There is nothing you can do to lower the risk of the breast cancers, and that's a myth because you can keep your lifestyle healthy, maintain a healthy weight, exercise regularly, and if you are drinking, you should limit as per the social norms for the alcohol. Ill-fitted bras causes blood cancer, and that's one of the most common spreaded myth. But there has been a numerous studies, and there wasn't any difference between women who are wearing bras and who aren't wearing any bras. Regular mammograms prevent breast cancers, and that's also a commonly spreaded myth. But in reality, it is the dose of the radiation in the mammography is too minuscule to cause a breast cancer. However, it is important and important to detect it early and therefore change the prognosis of the treatment. Sometimes many women say that they have small breasts, so there is no chance of getting them a breast cancer, and it is immaterial what is the proportion of the breast cancer can occur to anybody and is not affected by it. Many women say to us that they are very young, they can't have a breast cancer, and that again is a myth because many of the women, in fact 70% of them right now under 40 are being diagnosed with the breast cancers. Men can't have a breast cancer is again a myth because 1 in 922 men have a lifetime risk of having a breast cancer. Alcohol is not linked to breast cancer is again a myth because increased use of alcohol causes increased incidences of breast cancer. And only with women with the family history of breast cancer are at risk, and that's again a myth. All women are at risk. The family history just increases the risk. So how do we classify the stages of the breast cancer? So anything which is limited inside the breast is a stage 1 disease. Anything which is limited inside the breast and has spread to the nearby lymph nodes, these are the swellings in your axillas, or the armpits, that's the stage 2. When the tumor has spread to the superficial structures of the chest wall, has involved internal mammary lymph node. These are a series of the lymph nodes in between your chest. That's the stage 3. And when the cancer has spread outside the confines of the breast and the chest, it is known as a stage 4 disease. So the commonly involved sites are bone, liver, lungs, and brain. And therefore, the breast examination is a simple examination which has to be done monthly during the period of ovulation, preferably at the same time, and is as simple as 1, 2, 3. 1 in front of the mirror, 2 while lying down, 3 while bathing. In front of the mirror, just check for and look of the breast, feel for your breast, see any dimpling, size differences, nipple discharge, and inspect 4 ways: arms at the sides, arm at overhead, firmly pressing on hips and bending forwards. While you lie down, lie on your back with a pillow under your right shoulder and your right hand under your head, with the four fingers of your left arm making small circular movements. Just follow up and down pattern over the entire breast area, under the arms and up to the shoulder bone, press firmly pressing. Repeat same procedure using the right hand on the left breast, and while bathing also with your arms raised, check your right breast with the left hand and flat fingers using the same method as in previously. Repeat similarly on the other breast, that is the left breast with the right hand. What you have to look for any lump. If you have to look for any pulled up nipple, you have to look for any dimpling, you have to look for any discharges, you have to look for any redness, rashes, or skin changes. So the breast self-examination detects the majority of the breast cancer. It's the potentially life-saving monthly examination at the end of the menses. You can do it and you can detect it early and in an effective manner. You have to inspect for any skin changes, look for any redness, any visible lumps or bumps, or a nipple crusting or a symmetry. You have to raise the arms up. You have to see that the breast should rise evenly and watch for any dimpling or retraction. And feel for the lumps by raising the arms, feeling with the opposite hand. It just feels like a marble in the bag of the rice. The best method is using the middle of the fingers. So fingertips, usually when you do, they tend to poke a lot, and our fingertips are too sensitive. So everywhere we feel that there are a number of marbles inside the sea. So all breasts are somewhat lumpy. And palm is also insensitive. So the middle portion of the fingers is just the right method of do it. So start at one place, press in while circling with your hands, and feel for any thickening or the size of a marble. And move in small circles as demonstrated in this. Then move to another location, work your way around the breast in a circular clockwise fashion using small circles of the hand as you go. Make sure that the entire breast is being felt. Also, never ever forget to palpate or feel the tail of the breast. Since breast is not a perfectly round structure, the tail of the breast is actually a tail of the breast which is inside the axilla. That's the armpit. Make sure to feel any lump in that portion of the breast. Using the same circular motion, feel the armpit also. Feel for any breast lumps, lymph nodes. Normally, you can't feel any swelling there. It's just uh, if you feel anything, it's usually the lymph nodes, which are about the size of a pencil eraser but longer and thinner. And always try to express a nipple discharge. So strip the drugs through the nipple. Normally, one or two drops of clear, milky, or green tint solution excretions are common, but it should not be bloody or in large quantities, squirting out or staining the inside of the bras. Check on the other side. Following the same maneuver, raise the arm above your head, feel for any lumps or masses. And always have a professional breast examination annually. Basically, it involves the same maneuvers, asking the same questions, looking the same way. And what are the mammograms? Basically, they are usually routinely advocated between the ages of 40 to 50 years. And over the age of 50 years, it should be done annually. For patients with the breast problems or a family history, you should ask for from your treating doctor. And if you find something in breast, please don't panic. Many of these lesions are just not cancerous. But don't decide it by yourself. Go to the physician, a qualified medical oncologist, and he could help you with the same thing. And why it is important to meet them, because when they are caught early, in an early stages like a stage 0 and 1, you could see that people do survive 10 years out of that. And if it is a stage 0, that's around 90%. If it's a stage 1, around 80% of them. But as you go in a second and third stage and a fourth stage, the survival curve steps a lot. And that's why it is very important to be very apprehensive about what you have inside your breast. So, what are the guidelines for the cancer detection for the breast? The Americans usually recommend that from 20 years, you do a self breast examination monthly. From 20 to 40, a physician examination every 3 years. From 40 plus, physician examination every 1 year. A 35 to 40 is the initial mammogram. 40 to 49 is a mammogram every 1 to 2 years, and 50 plus is a mammogram every year. And why is that? The survival curves are now shrinking because we have a better surgical therapies, a better radiation therapies, a better diagnosis therapies, and a better chemotherapies. So the chemotherapies, which I am specialist, have undergone a paradigm change over the last few years. We have chemotherapies, we have targeted therapies, we have immunotherapies, we have hormone therapies, we have better supportive care, less of side effects, and the in history when you used to say the alopecia or hair loss used to be a common side effect with scalp cooling, it is becoming rarer and rarer. So look at these breasts. These are the typical examples of how the skin dimpling, the lump should be filled out. And when you do these breast examination and you find something positive, just go and visit your doctors to have a complete set of examination. Usually what is recommended next when you feel a lump is the mammography, a sonography, a cytology, a biopsy, and then we depend upon the breast cancer, how it is, at what stage it is being diagnosed. So what are the risk factors for the breast cancer? First being a female, second being age, third being any family history of or a first degree relative having a breast cancer and ovarian cancer, menstrual history, and uh, 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 childbirth more than 30 years is again a factor, and long-term hormone therapy for postmenopausal women again increases the risk of the breast cancers. And oral contraceptives again have a slight increased risk of breast cancers. And a prior radiation therapy exposure also increases the risk of the breast cancer at young age. Obesity, diet rich in fats, alcohol again is a factor. There are BRCA1 and BRCA2, or commonly known as BRCA, are the mutations which are commonly expressed in the breast cancers. And how do you assess the breast cancer risk? It's basically you look out at these factors. Age being the first, age more than 35 years, the first degree relative with the breast cancer, any prior breast biopsies, age at menarche, age at first childbirth, and ethnicity. And that's how you give a scoring. When you have a BRCA1 or BRCA2 mutation, you have a relative risk of 10 is to 32 times of being diagnosed with a breast cancer. With a family history of cancer, that is first degree relative 2 times, 2 first degree relatives 3 times, 3 or more first degree relatives 4 times, and a first second degree relatives around 1 to 1.5 times. Any radiation to the chest wall gives a risk of 7 to 17 times. Hormonal factors, that is either late parity, of that is a late first childbirth, or a no childbirth, again 1.2 to 1.7. An early age menarche, that is less than 12 years you start your menses, or a late menopause, that is more than 55 years, again you have a chances of breast cancer of 1.2 to 1.3 times the normal population. A combined hormone replacement therapy, again 1.5 is the risk factor. And alcohol consumption again is a risk factor. Smoking again is a risk factor. Sedentary lifestyle again is a risk factor. Right race is again a risk factor. Breast, a very dense breast again is a risk factor. And what influences the survival? The age at which it is being diagnosed, the stage at which it is being diagnosed, the size where the tumor is being diagnosed, and what are the hormonal factors, the hormonal receptor, or it's a HER2 status about it is. You have to look for the masses. You have to look for any microcalcification. As you can see, these specks of calcifications or the speculated appearance on mammography, as you could see from these. And therefore, we have the classification of it, as I showed in the diagram. That's usually expressed in the T and M classification. T being the tumor size, N being the nodal status, and M being the metastatic sites. And I discussed what was the staging of these breast cancers and what is usually the treatment. For a early stage cancer, you have to remove that cancer. You have to then examine it periodically after the removal. For DCIS, that is ductal carcinoma in situ, which are hormone sensitive, we give hormonal therapy for 5 years. For after the breast conservation surgery, which is usually practiced, which is as good as removing the whole breast in an early stage of the breast cancer, we have to give some chemotherapies and followed by radiation therapies and followed by hormonal therapies for those who are hormone sensitive. For those who are stage 3, you have to do the surgery, either the lumpectomy or the removal of the whole breast, followed by chemotherapy, followed by radiation, followed by hormonal therapy if they're sensitive. For stage 4, there is a whole paradigm of therapy that has come, which include the primary management involves the chemotherapy and the hormonal therapy and a targeted therapy depending upon the status. What could be the complications of the surgery? Usually 10 to 30% of the patients who undergo an axillary dissection or a sentinel lymph node biopsy tend to have that lymphedema, that is the swelling of the arms. There is usually numbness, there is reduced shoulder mobility, the psychosocial problems of mastectomy, and always a phantom breast sensations. Radiation reduces the risk of recurrence, may improve the survival. And there are various methods of giving a radiation. Either you give the whole breast radiation or you give a partial breast radiation. And the underlying treatment always involves a systemic therapy, which includes chemotherapies, hormonal therapies, targeted therapies, and a whole lot of changes. And the chemotherapies have evolved a lot during the last frequent years. We have numerous chemotherapies options, numerous hormonal therapies options, numerous immunotherapy options, and all of them have shown a survival benefit over the past few years. So although breast cancer incidence has been increasing, the mortality rates due to breast cancer are reducing. Advances in the conventional therapy, including the less radical surgery and reduced radiation fields, the cytotoxic chemotherapy has evolved a paradigm change over the last few years, including the types, the doses, and the scheduling. We have hormonal therapies, targeted therapies, immunotherapies, and the treatment now is an individualized chemotherapy, a selective therapy for a selective patient. And that is the end of my talk. I am ready to take any questions if there are any.
Thank you, Devashish. That was indeed informative. And I now request all the questions in background of Dr. Talreja's video to be put up in the chat box for Dr. Talreja's immediate reference. Who will now be joining us on 5:45 for Q&A. We are now honored to have Dr. Rachna Rahotgi with us. I would like to request Dr. Shilpa Khatri Babbar to kindly welcome her. Over to you, ma'am.
Thank you, Amisha. A very warm welcome, Dr. Rachna. Dr. Rachna has done her MBBS from MAMC, her post-graduation diploma and diplomate of National Board in Gynecology from St. Stephen's Hospital. She has delivered several lectures and written for journals of international and national repute. She's always insisted on the significance of self-care. To all my gender champions here, you would be glad to know that she's almost always quoted in discussions and write-ups on role of gender ideology and work-life balance. I know Dr. Rachna Rahotgi less as a doctor, but more as a beautiful human being whom we always bother on our alumni batch group. And thank you so much, Rachna, for taking out time for all the participants and especially my young budding children who want to put society before self. Over to you, Rachna.
Thank you so much. Am I audible first and visible to all of you? First, let us check that.
Yes.
Yeah. So, good evening, everyone. I'm Dr. Rachna Rahotgi, as Shilpa has, introduced me. I'm an obstetrician and gynecologist. I would like to thank the organizing committee of WIPS for giving me this opportunity. I would also like to congratulate the student body of WIPS for their enthusiastic participation. I've been seeing the Facebook and the role plays and lot of write-ups on there. So I think you all are well-read people, and we want to make this session very interactive. I don't want it to be a monologue that I keep on, burdening you with lot of stuff on breast cancer. So I'll be asking you questions. You have to, please don't unmute and just write everything on the chat box. And secondly, we might, I will be demonstrating how breast self-examination is done. So in that case, you will have to, if you feel nice, you can open up your videos and you can practice it with me. So today I'll be discussing breast cancer. Mainly I'll be highlighting the high risk factors, what are the clinical symptoms, are the warning signs, and the screening part. At the end of the talk, I'll be happy to take your questions. And so let's start with the discussion. First, children, what do you understand by breast cancer? Has anybody read it up? And you can just write it in your chat box. What do you really understand by breast cancer? Let's start with the basics, it's important. So in simple language, a breast cancer is a disease in which the cells of the breast grow out of control. Next, I will be telling you about the anatomy of the breast. Now, the breast, you should know, it consists of lobules. Lobules are the milk-producing glands. And the lobules are connected by tubular things like called the ducts, which open into the nipple. We have the connective tissue, which is the fibrous and the fatty tissue, and the nipples and the areola. So this is the basic, the structure of the breast, because if I'm discussing the breast cancer, you should all know what is the, what is the breast cancer and how does a normal breast in a very simple language looks like. Now, can we start sharing the slides now? I think, yeah, now we can move to the, the next slide, please. Yes. Now, let us discuss what's the burden of breast cancer in India. According to the National Cancer Registry Program released by the ICMR, 1 in 29 females is a patient of breast cancer. Next slide, please. Why should there be breast cancer awareness? Now, this is a very relevant question. Why are we, holding these breast awareness programs? Well, where is the need of this? There is an increasing number of cases of breast cancer, especially amongst the younger age group, women amongst 30s and 40s. It is one of the most common cancer in India in females, followed by the cervical cancer. In India, especially, we are having a lesser survival rate in breast cancer as compared to the US. The 5-year survival is, around 60%. Now, what are the reasons for it? Reasons are mainly the lack of awareness. And we are not, taking up the screening methods. So it's very, very important at this stage when the cases are rising and we have the younger populations. We need to be aware of it. Next slide, please. Here, I would also like to mention that breast cancer, though we always talk in females, is just not limited to females. It affects both men and females. So men too have breast cancer. Though the incidence is comparatively less, around 1% of the diagnosed male breast cancers are in the world are male breast cancers. But unfortunately, the mortality of the breast cancer is pretty high. It's around 19% higher than the diagnosed woman. So it's very, very important. That's the rationale behind the breast cancer awareness programs. Also, we are dedicating the whole month of October, which is called the Pink October, to create awareness at different levels about this cancer. Now, can anyone tell me what is this pink ribbon stands for? We are putting up in all the slides and all the programs. Can anyone tell me? Are you using your chat box? Any one of you? Actually, I am not unable to see that. Do we have any answers from the audience?
No, ma'am, not yet.
Okay, so I presume that nobody knows what this pink ribbon stands for, and we are putting it up everywhere, right? So that the pink ribbon is an international symbol for breast cancer awareness. And the bearer of it shows that it is supporting the cause of breast cancer. This is very important to understand what we are doing in the month of October, why we are calling it Pink October, and what does this, pink ribbon really stands for. Now, I would ask another question. Have you all heard about Angelina Jolie, Oscar-winning Hollywood actress? So I think this should interest the students of WIPS. And what is she really famous for? And why am I really mentioning her in this awareness program? Can anyone really tell me? Anyone, I mean, like the faculty or anyone, I would love to hear someone, interact here and tell me what is so, famous about this Hollywood actress. Shilpa?
Yeah, so we have a reply from the student. So there is Supreet.
Yeah, when I speak of Angelina Jolie, I do expect an answer now.
Yeah.
Ma'am, we just got a reply from Supreet Kaur. She's saying that she is a breast cancer survivor.
No, that's not correct, beta. That's really not correct. Any more answers? Well, what is so famous about Angelina Jolie? So let me tell you now. She found
so there is another answer. Sorry,
yes.
Yeah, Rachna.
Huh?
Oh, couple of more. So come on, Shambhavi, go ahead.
Let's see. अब उन्होंने Google कर लिया होगा, I'm sure. So, children are very smart these days, but let us see. Now, one answer was wrong. Now, let us see.
Another answer is from Divyam Sharma that she went through mastectomy to prevent cancer.
Yeah, that's quite true. Actually, she found out through genetic testing that she is at high risk for breast cancer because of her family history. And so ultimately, she decided to undergo prophylactic. Prophylactic means preventive, means before the disease is diagnosed, bilateral mastectomy to reduce the risk of developing breast cancer. So, this is the, inspired being Hollywood heroine, and, breasts are the basic assets. And so still she, underwent this procedure. So this is a very inspiring thing. So I brought it up here. And I think, though there are many real life heroes and which we fail to mention, but yes, all the cancer survivors and who have been taking a lot of steps to, prevent this disease and create awareness, they all appreciate. So now I'll be discussing the high risk factors. Several high risk factors have been of breast cancer have been documented. I think in the previous lecture I was listening. There was a battery of lists. I will be, dealing with very specific ones. First is the family history of breast or the ovarian cancer. There are some mutations in the BRCA gene, 1 and 2. And what do you understand the BRCA? That's the breast cancer gene. Okay. These results, these mutations give rise to the cancer. They are very much prone to the cancer. But now when I say this, it's not, please do not panic that I have a family history, now I'm going to develop a cancer. So it's not, generally very true. But yes, there lies the, if you have a family history, you should undergo genetic counseling and undergo genetic testing of these two genes, BRCA genes. So this is one important thing which I want to highlight in very simple ways. Next is the reproductive factors associated with prolonged exposure to estrogens. Early menarche, you attain your periods early, a late menopause, late age at first childbirth. So these, lead to more estrogen exposure, and these are certain reproductive factors which are associated with breast cancer. Breastfeeding, is said to be protective for breast cancer, and those women who are not breastfed, they are generally said to be having a higher risk of, breast cancer. Certain exogenous hormone intake, like oral contraceptive pills, generally the hormone therapy users, HRT, which after menopause, if you are aware, certain women go in for these HRT. So they are at higher risk, especially with the oral contraceptive pills. There's about 10% increased risk for less than 5 years of use. So current users, and they are more prone to this cancer. A personal history of breast cancer. If you had a breast cancer before, you are more prone to develop it again. So, and now the main important thing which I would like to discuss is the lifestyle related, breast cancer risk factors, which are obviously considered to be modifiable modifiable risk factors. So these are alcohol overuse, abuse, or the obesity, physical inactivity. So these are the lifestyle. So we are seeing breast cancer more in the urban areas as compared to the rural areas. It's a disease of the westernization and the urban areas. And here comes the importance of lifestyle modifications, and which is very important, to engrave in the, right from the beginning, for the students to know that, it's important to eat a healthy, nutritious diet, good and fruits and vegetables. And then they should, exercising daily and check their weights. And obviously, consumption of alcohol should be in a limit. Now, I would like to discuss, the risk factors in the male breast cancer, because we should talk in both ways, not only about the females. So, a male breast cancer generally, develops as a lump in the nipple and the areola region. It also is associated with the breast cancer. Generally, it is associated with the breast cancer gene 2 and with the prostate cancers. And the other risk factors associated with male breast cancers are generally exposure to estrogens. When the people are taking hormone therapy for prostate cancers or any other cancer, they develop this male breast cancer, though it's very rare as compared to the female breast cancer. Then certain chromosomal problems, like Klinefelters, they're an extra X chromosome, if you're aware of the X and the Y chromosome. So these Klinefelter or the chromosomal anomalies can also lead to this male breast cancer. Certain, liver disease, like cirrhosis of the liver, testicular disease, or the surgeries of the testes, they're also predisposed to male breast cancer. So these are the, briefly I have put up the risk factors which are very important and which you should know. Now I will be discussing the clinical presentations. What are the warning signs and when you should really go to a doctor. That's important for all of you to know. If you have, what alarming signs that you should, consult your doctor. For that, first we need to understand one basic thing: a breast undergoes normal changes during the onset of puberty, during pregnancies, which we all know. During, menopause, they shrink and there's atrophy of the breast. And during any weight change, if you gain weight, you lose weight. And even during the menstrual cycle, there's a lot of breast tenderness and other things. So these are the normal physiological changes. So certain changes in the breasts are normal. Okay. Now, what is the warning signs of the breast cancer when you should alert? Be alert. Ki this is something different, and I should really now consult a doctor. First important thing is a change in the size or change in the shape of the breast. It can be one breast or both the breast. So change in the size or the shape of the breast. Another important thing is you feel a lump in the breast area or the armpit, which generally persist. Most of the lumps, they are, after the menstrual cycle, after you finish your periods, they just disappear, but they will persist. Very important changes in the nipples. That's very, very important to note. The nipples turn inwards. This is we call the nipple indentation or the nipple retraction. There will be, abnormal nipple discharge. The nipples will be, the discharge from the nipple can be bloody or clear. It will be a very different kind of discharge. And you can feel nipple pain in your nipples, soreness, itchiness. Sometimes, breast cancer is also associated breast pain, but it's not a very specific feature. Next important thing from the nipple changes in the nipple is the changes in the skin of the breast. That's very important. The skin generally appears red, swollen. It might be red, it might be swollen, or there can be skin dimpling, which we call characteristically an orange peel, appearance. That's very, very important, that orange peel kind of appearance. We can have swollen lymph nodes. All of you might be aware that, the breast cancer, spreads through the lymph or the blood. Okay. So sometimes the breast cancer can spread to the lymph nodes, and under the armpit, in your armpit area or near the collarbone, you might feel a lump. So it's not necessary that you are feeling a lump only in the region of the breast. So the surrounding area is also very, very important. So if you have any of these symptoms, it's a good idea to go fix an appointment with your doctor and consult and go for testing and other things. Next slide, please. Yeah, this is the very simple representation of all the signs and the symptoms. Now I'll be talking about the screening of breast cancer. How do we that's the main important thing. What are the modalities available for screening of the breast cancer? Now, can we have the screening slide here? Yeah. So generally, for the screening of the breast cancer, we have modalities like breast self-examination, a clinical breast examination, which is done by the doctor, and we have mammography, which is the gold standard, and this is the one basic thing which we should know, and the breast ultrasound. These are the basic, screening tools available to us. We will, let us all learn how to do a breast self-examination, because that's the most important thing that, we can do at our levels, So before, what do you understand, all of you, by breast self-examination? Can anyone, write it in the chat box, breast self-examination? What is this breast self-examination? What do you understand? Have you ever done it? Have you started doing it? Are there any answers here? Is there any answer?
Beta, you need to, okay, so Supreet is there.
Ma'am, we just got a reply from Supreet Kaur that it's a way of examining any changes in our breasts.
So yeah, it is basically a visual inspection and the palpation of the breast tissue, and it is done in the sitting and the lying position. So my request to all of you is, probably you can, practice the postures at least with me so that it gets, engraved in your minds. And if some of the students are enthusiastic enough, they can, put on their videos and show. It will be a nice demo also. So before I start with the breast self-examination, I would like to tell you what is the extent of the breast and how does a normal breast feel. So this is very important to understand. Can we have the breast self-examination slide, please? Step 1, yes. So now the normal breast extends horizontally from the edge of the sternum. Does everyone know what sternum is? It is a flat bone which we feel in the center of our chest. Now, everyone should, palpate what is sternum, and, make it sure that you know what sternum is. And to the mid axillary line. Now, what is this mid axillary line? This is in the center of the axilla or the underarm. Your underarm area, the center of the line. So, this is the horizontal spread, the center of the breastbone, okay, of the chest bone to the line passing through your underarm. This is the horizontal spread. Now, from vertically, it extends from the collarbone. Please feel your collarbone, all of you, so that everyone is sure where you remember what exactly to look into. And it extends to the upper crease below just where the breast ends. So this is the area which you should consider while doing a breast self examination. Now, my second thing which I want to tell you practically is, what does a normal breast feel? If you do not know what is the feel of a normal breast, so it will be very difficult for you to find out what is abnormal. So the whole purpose of this explanation goes waste. A normal breast feels soft, and it has a doughy like consistency, doughy like feel. And with pads of the hand. Now, what are the pads of the hand? Can you see these pads? These are the pads of the hands. You generally feel it as lumpy, grainy, or pebbly kind of thing. So this is a normal feel of the breast, and I have talked about what is the extent of the breast. Okay. So now, why are we doing this? Breast self-examination. What is the purpose of doing this? The main purpose of doing a breast self-examination is to get familiar with your breast. And when, if you're doing it regularly, you will get familiar with your breast and you can pick up any kind of abnormality. So that's the purpose of doing it. Now, the thing is, when should we start doing breast self-examination and what is the good time? Because most people are not aware of it. I think we are saying that after the age of 20, it's a good time that we start examining our breast, becoming breast aware. So that is very, very important. And it should ideally not be done very frequently. We should do it on a particular day of the month. And generally that should be a few days after your periods have stopped. You are finished, because during your periods, the breasts are very tender. So the whole purpose of doing the breast self-examination is defeated. So please do it, schedule it on a fixed date when your periods are generally, over. So that would be a good time to do it. And now, another thing which I want you to note here is very, very important is that breast self-examination does not, replace the clinical breast examination or a mammogram. So this is very, very important to understand that breast self-examination is something which we are doing to be aware of our breast, and we can actually, if we find any problems, we can go to our doctor. But in no way it is now, replacing the importance of clinical breast examination and a mammogram. So this should be a very important thing which should be clear to everyone. Now let us start with the steps of breast self-examination. We have tried to put up some slides, but yes, you can practice it with me. At least you can, the postures in which you should be doing, that would be good. So now in the step 1, you look at your breast in the mirror, arms by the side or on the hips. You have to check for the usual things which I have discussed, in the, clinical features, the various changes in the skin, lump, and the nipples. That all those features you have to see. So this is the first position. You have to stand in front of the mirror, and your hands can be either on your side or by the side of yours. So this is step one. Hope I am clear, and I can move to step two because this is something which I want to teach you before I, end my lecture. So is this clear? Can we move to step two now?
Yes, ma'am.
Yeah. So in step two, now you put your hands behind your head like this and check the appearance again. So this is step two. Now, I hope this is clear or need to repeat it. This is very clear. So here in step one and step two, basically you're inspecting the breast. You're standing in front of the mirror and you're just, you're in one, it is hands are on the sides or by the hips, and in the second, they are behind your head like this. And you're examining your breast. Now the step three, this is done in the lying down position. Okay. Now you can lie comfortably on a bed, on your back. Right arm should be up. Please see the figure here. Right arm up. Okay. And the pillow should be behind the right shoulder. If you're examining the right breast, so just remember this rule. If you're examining the right breast, then the right arm should be up. Okay. And the pillow should be below the right shoulder, and with the left hand. So it's opposite, like if you're using the right hand, if you want to examine the right breast, you have to use your left. You have to now feel the entire breast and the surrounding area. And you have to feel for the similar things, like if there is any lump or thickening or any different kind of tissue with it. So I hope the step three is absolutely clear to all of you, that this is done in the lying down position, and basically, you are palpating, you're feeling your breast in this step. So is this very clear? Can we move ahead to the step four?
Yes, ma'am.
Yeah. If you want me to repeat anything, because this is something which is not clear to most of females, and they are always wondering how we should do, because many people are telling you should examine your breast, but how we should do it. Step four is in the standing or the sitting position. Okay, you can either stand or you can sit on a chair. And some, females find it easier to do while they are taking a shower or with the lotion, because then the breasts are slippery and they can easily, feel it. So in this also, we are, examining our breasts, feeling them for any kind of abnormality. You are now recording all your observations and mark the calendar for the next week. This is the, the basic steps. So do I need to repeat these steps, or we can move ahead?
Ma'am, we can move ahead.
Okay. Now, what should be the pressure? The pressure we should apply pressure. It should be firm but gentle. This is important to note. First, it should be a very superficial, soft kind of a pressure to feel under your skin. Then a medium kind of a pressure where you can feel the deeper tissue. The third pressure which you should apply should be a very firm pressure where you can feel the breastbone and the ribs. So you have to feel, because breast cancer sometimes is very deep seated, and especially if you have dense breast, you might miss out. So this is the, the pressure thing. And can I have that pattern slide, please? Follow the pattern. You have to follow a pattern. So they can be, you can choose any pattern which you are, familiar or you're comfortable with. Like you can go start with the nipples and go circling outside, or you can do an up and down rows, or you can divide the entire breast into sections and feel it. Your fingers should all the time be moving in tiny circles. So I think with this, I complete my breast self-examination, and I hope we should take from certain of your students, if they have followed it, if there is anything they want me to repeat here, I would be very happy to repeat. If they have not followed any step, or they want me to, probably repeat it. Can we have some answers from the audience?
students feel free
Yes.
altogether. It will be
This is
kept.
something you're going to practice, because what is the purpose of telling you a lot of big things, but when what you can do, that is something I want to discuss and make clear. So, students, if these things are not, any of the step, have you followed? Is there any response?
It is
So
a request to all the attendees. If anything is not clear, kindly raise your hand or put it up.
yeah, so they say that it's absolutely
It's
clear.
very clear.
Yeah, yeah.
Okay. So now we will move to the gold standard of screening, that is the mammogram. So can we have the mammogram slide, please? Yes. Now mammography is now considered to be a gold standard for the screening. We are offering mammograms right from the age of 40, and we are doing annual screening. It is, what is mammography? Most of the people, I've put up a picture so you can basically understand how it is done, how the machine is and other things. It is a low dose X-ray test. So basically it's an X-ray technique test, okay? And the breast tissue is put on the ultrasound machine, and it is gently but firmly pressed between the plates. Can you see these plates? Is it can you understand this? These are the plates where the breast is compressed, and then we are taking the films. This is how is the the basic procedure for it, because I've seen most of my patients don't even know what is a mammogram, how it is done. Next slide, please. Okay, now mammogram is a very simple OPD procedure. It has high sensitivity and specificity. What are the basic instructions, which a patient should be clear, because they have many doubts when we should go for a mammogram, and what we should do before a mammogram. So it should ideally, the patient should go when, a week after their periods have settled. This is for the screening mammogram. Please mark it. This is for a screening mammogram. If you have any problems, you've detected a lump, you should go immediately, and what your doctor advises you, you should follow that. Go for the screening. Then it should be ideally, you should not be applying a lot of lotions, talcums, and other things, because they appear as calcium spots. So these are, and if you are pregnant, then obviously you should not take up this test because it involves radiation. And now I would like to say what are the now not so good about mammograms. We always talk it's a very good screening technique, but at the same time we should know what is not so good about mammograms. It is associated with false positivity. 5 to 15% is the false positivity rate. So sometimes it can create some panic. It can pick up some very innocent lumps, and then the patient has to be followed up with a lot of mammograms, and sometimes even they are subjected to biopsy. So this is one thing, because if we are doing a lot of tests, so this is something one of the not so good part about mammogram. And secondly, a small radiation. Now, another thing is what myths, most of the patients they come up with, if they are doing so much of mammograms each year, so what radiation effects it can have. So let me clear it out here. That, mammography has a very low, screening mammography has a very low radiation exposure. So the benefits which we reap out of detecting early stage breast cancer is much higher than the small radiation dose we get. So all the females who are above 40 should go to the doctor, should take up this clinical breast examination and a mammogram. Now in this slide we are seeing how an ultrasound clinical breast ultrasound, how we are using this. So now in dense breasts, sometimes the breasts are dense. So mammogram is, the sensitivity and the specificity falls, it is not very good in cases of dense breast. So what we are doing is we are, doing both with the help of a radiologist. we are actually doing both. We are doing, ultrasound breast and the mammogram. Both of them are done. And on base of the things, we are deciding and giving a final report. So sometimes both ultrasound breast and a mammogram is offered to the patient. Next slide, please. Now I would summarize, by saying a very important, take home message for all of you is knowing it exists is not enough. So we should get it formed and pass it on. So this is the whole concept, behind the breast screening procedure. And next slide, please. This is a very, my favorite quote of Benjamin Franklin. An ounce of prevention is worth a pound of cure. So this is very important for all of us to understand that we all need to be aware of our breast. We should, do breast self-examination. We should maintain a healthy lifestyle and go to a doctor as early as possible if you pick up something. So I think this is, I wind up my lecture here, and I now be very happy to take your questions, and I hope now we will have a better interaction from the audience.
Thank you, Devashish. You can now stop the sharing.
Yes, thank you so much, Devashish, for sharing the slides, and I'll be happy to take your questions. Yes.
Before the questions, Rachna, these students have been insistent on showing their gratitude for your highly enlightening lecture. So yes, so you wanted to show a thank you screen to ma'am with, I'm told, flowers falling on her. Please go ahead.
Oh, thank you so much. That means a lot. This really means a lot. And I should tell you, Shilpa, your students are, I've interacted with two of them yesterday, and they are so enthusiastic and, so, ready to help and all those things. And, you are blessed to have the students because, these days, and they are, what best thing is that they are participating for this and they are very curious to know and get aware. So this is one good thing. Thank you so much. This was
we are blessed to have a mentor like her.
Okay, can we stop sharing that screen, please? Indeed, yeah, I'm blessed to have them. There is no doubt about it. I would like to inform the audience that we have, I know, a lot of questions for ma'am, and we also have questions for Dr. Vikas, who had to, due to some emergency, leave. So I'm knowing Rachna without even seeking her permission. I'm sure she'll be able to take out time for those questions. So could we have the question answer round, please?
Yes, please go ahead. I'll try to do justice with all your questions. So let's start. Yes, please.
Ma'am, the first question we have is, what is the...
First, introduce yourself. I'd like to know your name.
Ma'am, myself, Omisha Kathuria. I'm the moderator for this webinar.
Oh, wonderful, wonderful, Beta. Now, yes, please, Beta, start with your question.
Yes, so the first question we have is, what is the meaning of dense breast?
Beta, dense
that
breast?
Question, sorry, Rachna, if they don't mind, ma'am would love to know who has asked that question. And
it's Vivekananda Institute of Professional Studies.
Okay.
Yes, so I would appreciate, to know, like this, who is asking the questions. So, it is good to know people.
Actually, the username is Vivekananda Institute of Professional Studies. So, yeah.
So dense breast is, some, ladies have mentioned in my lecture what is, some ladies have dense breast. When we are screening it with mammography or with ultrasound, sometimes the breast density is very high. So it is very difficult to, pick up a lump there. So in those cases, we are, doing both the mammography and the ultrasound. So the breast density which we see, that is high. So that is the, meaning of a dense breast. It does not mean a big breast or something like that.
Thank you, ma'am.
Yeah,
The next question we have is from Supreet Kaur. She's asking that to what extent does the surgery for treating breast cancer affect the mammary glands of a patient?
see, that would depend. Surveet, right?
Yes, Supreet. Supreet.
Supreet, yeah, she's been very active. She, answered most of my questions. So, Supreet Beta, basically that would depend on the type of surgery, how much, effect is going to have on the breast tissue. Sometimes when we are now detecting the cancer early, let's say in the, stage 1, we are offering them even just a removal of the lump, and we are preserving the breast. So in that case, the damage to the mammary glands will be less, and sometimes we are, doing just a simple mastectomy. We are just removing one breast. And sometimes when they are coming in the advanced cases like stage 3, stage 4, we are doing a radical mastectomy where we're removing all the breasts, and we are removing even the lymph nodes and the underlying muscles and all that. So it all depends on the type of the surgery. And more, that's important, that if we detect the cancer early, so we can offer them more options, more breast conserving surgeries, and we can, preserve the whole, composition and the structure of the breast to as much as possible. Because anyway, if you're doing a surgery, removing the breast tissue is going to affect the mammary glands. And it also affects the breastfeeding if the mother is lactating. So I hope I've answered.
Yeah, I hope, Supreet, that very well answers your question. We now move forward to Namrata Singhal's question. She asks, she's asking that is there any possible association between the breast implantation and breast cancer?
See, breast implants, they might, have a small incidence of increase in the breast cancer, but generally the latest kind of which we are putting in, they are not, very much predisposing to breast cancer. They might increase to a certain extent your breast cancer incidence, especially if you have other risk factors associated with it.
Another question is from Shikha Shrishti. She's asking that can mothers feed after surgery?
Okay, this is Shikha Shrishti. Hello, beta. Now, the thing is, once the patient has delivered and undergone breast cancer surgery, so it will entirely depend, if the patient wants to feed, she should first discuss it with her oncologist and doctor whether she can breastfeed. Most of the time, when the patient is undergoing breast cancer surgery, like mastectomies and other things, we are in advanced cases, we are offering them certain chemotherapy, certain hormone therapy, and they are secreted in the breast milk. So it will not be a good idea for breastfeeding, and then the doctor will say that this is not good for the breastfeeding mother, and she can probably, stop the breastfeeding for some time till these harmful things are, till the chemotherapy dose is finished. But yes, if breast surgery has been done and the patient is not undergoing any kind of adjuvant therapy like or post-op therapies like radiation or chemotherapy, she can breastfeed. And obviously the if both the breasts are removed and no breast tissue is there, so she obviously cannot breastfeed. If this is possible only when there's a simple one breast has been removed and the other breast is there, so she can feed from that breast, or only a lump is. If you remove the entire tissue, then the point of breastfeeding does not hold. So first of all, she should have a breast tissue which is where she can feed, and secondly, she should not be on any harmful radiotherapy, chemotherapy, or other kind of things which are secreted in the breast milk, and it can harm the child. And obviously, before surgery, also sometimes we are saying that we should not be breastfeeding because sometimes breastfeeding can, increase the blood flow and increase the chances of infection. So even before the surgery, we are stopping this breastfeeding. But anyway, there should be a discussion with your doctor. Next question, please.
Ma'am, once the breasts are removed and I've heard of reconstruction of breast as well. So can a female breastfeed after reconstruction of her breast?
No, no, no. I mean, that's an artificial procedure where we are, reconstructing the breast is mostly cosmetic and all, but generally, and there's a lot of damage to the breast, with the radiation and the chemo. So that's a difficult aspect.
Thank you, ma'am. Another question is from Mrs. Hani Bhatia. She is asking that we have often seen that cancer reoccurs within 5 years. In case of breast cancer, how much chances of reoccurrences are there?
See, that will, they cannot be, a specific incidence percentage can be quoted to it. That and we cannot fix up a time also कि 5 साल में ही आ रहा है या 2 साल में ही आ रहा है. So sometimes, it once the cancer, once a person has a cancer and she has been treated. So how good the surgery has been, whether we have successfully removed the whole tissue and whether we have successfully removed all the surrounding areas and how consistently how good the surgery has been. So the recurrence chance is quite less, but yes, person is definitely prone to a recurrence, and it should be kept in mind. It's one of the high risk factors.
Thank you, ma'am. Also, another question is from Anshi Mudgal. She's asking that is there any yeah, that's the same question. Is from Shambhavi Sharma. We have another question. At the time of pregnancy, if a woman is diagnosed with breast cancer, what should be the way forward for her? Are there any complications related to well-being of the child? And what are the related repercussions?
So who asked this question? Can I?
Shambhavi Sharma.
Shambhavi Sharma. Okay. Hello, Shambhavi. So this is a good question, and thankfully it is related to my field also. So, see, if a person is, if a lady is diagnosed with breast cancer in pregnancy, it is a definitely high risk pregnancy, and a lot of support is needed to the mother. In the first trimester, generally the time of the surgery, if it is, is good, if you have to operate, it is a good time in the second and the third trimester. In the first trimester, we try to generally avoid any kind of radiation or any kind of, chemotherapy, because the organogenesis is taking place, the fetus is being formed. We do not want to subject them to any kind of these harmful things which might affect the development of the baby. So sometimes if the lady is just unfortunately detected with an advanced breast cancer in the in the initial 3 months of the pregnancy, and she has to be operated and put on a chemotherapy and a radiation, we sometimes even have to counsel her for termination of pregnancy. And in the second and the third trimester are obviously good time for for operating the lady. In when we have a lot of time before the patient delivers, second trimester, something generally we try to do, we try to do a complete mastectomy and try to avoid the breast conserving surgeries, because breast conserving surgeries are often we have to follow them with some kind of adjunct like chemotherapy and other things. By far in pregnancy, chemotherapy is safer. We use certain safer chemotherapeutic agents like taxane, cyclophosphamide, doxorubicin, etc. And so safer chemotherapeutic agents are used. And in the once the patient, if we are detecting at the time when she's just about to deliver, we can give her the options of breast conserving surgeries, and probably once she delivers, we can give her this chemo or radio or whatever the oncologist feels. And obviously in the first, this has a lot of impact on both the fetus and the mother, and a lot of reassurance and support has to be given to the mother. So hope I have answered, and if there is anything further she wants to know, I would be happy to answer. We can move to the next question.
Yes, Shambhavi, you can add on if it is not clear. I think that is... Thank you, ma'am. Moving to another question.
Yes.
It is from Mrs. Tehzeeb Fatima. How long should a lump be there before it should become a concern and requires a visit to a doctor? And are all lumps dangerous? or lump dangerous?
Okay. Hello, Tehzeeb. It was wonderful. First of all, it was wonderful associating with you, and you really helped me with all my queries. Okay. Now the answer to your question is that, see, all lumps are not, cancers. I mentioned it, in my lecture. So please do not panic. I have got a lump now. It's a cancer, and now everything is gone. Just 8 out of 10 lumps which we detect can be cancerous. Mostly, most of the lumps go off by our menstrual cycles. Once we finished our periods, if you feel a breast lump and we just, to get off with our periods, and a week or later, if generally, if you're not feeling them again and they're not persisting, so then we can just, be watchful. But yes, if they are persisting and if they are associated with any other kind of features which I mentioned, like, changes in the skin or in the nipples, or, so you should not contacting your doctor. So have I answered, Tehzeeb? Or is there anything
Yes,
further?
ma'am. Thank you so much.
Yeah, welcome, welcome. Good to see you, actually.
Ma'am, we also got a reply from Shambhavi Sharma, who is saying that thank you so much, ma'am. It's absolutely clear.
Okay. Most welcome, beta. Now, are there any more questions?
Ma'am, yeah, this will be the last question I'll be entertaining.
No, I'm happy to answer. No worries. I mean, it's
Okay.
good to interact, because if the lecture is a monologue, it does not interest anyone. So, and I am happy to answer as many questions. So please go ahead.
We are grateful, ma'am. Thank you. So up next is from Yukta Mahajan. She's asking that if someone is diagnosed with breast cancer, then how should one go about with the treatment procedure, and what are the possible expenses?
Okay. Hello, Yukta. So, this question entirely depends on when you are getting your breast cancer detected, in which stage or which grade you are in when you are, and what's the exact spread of breast cancer. So the cost and the type of the surgery will depend on that. Generally, if the breast is detected early, let's say in stage 1, we are offering them breast conserving surgeries, like only the lump is removed, which we call lumpectomy, or quadrant is removed, or simple mastectomy is offered. But yes, if it is detected late, you know we are we have to do a radical mastectomy. We have to remove the entire breast. The lymph node dissection has to be done, and we have to give even the radio, chemo, and all those things. And depending on that, the whole expense is, and obviously it is a very economic burden on the family, apart from the emotional and the psychological effects. So cost is definitely depending on the surgeries and the stage you're going to be detected.
I hope that answers your question, Yukta.
Omisha, since Dr. Samir has joined us, but there's one last question from a boy, and I don't want to disrespect that.
Yes,
Can you take up that question, please?
Of all,
Yes,
I'm
ma'am,
very
sure.
consistently following everyone, and generally I've not seen the boys interacting, though I have really told them that it is very important for men to be aware, and
So here we finally have a boy with a question.
yes,
So
most welcome. So that should not be
this is from Ishank Buddhiraja. In men, only obese men with male breasts are prone to breast cancer, or anyone in general can be diagnosed with it?
So what's his name? Ishan.
Ishank.
Ishan Buddhiraja, hello, and I really appreciate your inquisitiveness on this matter. So first of all, I like to clarify, it's not that only one person who is developing male breast cancer has male breast. So all men have a breast tissue, and it is a male breast. Everyone has it. Like all females have breast, so all men also have breast, but the tissue is comparatively not so developed in men. And it's obesity is one of the factors in both males and females, but it cannot be said that all obese men will have cancers. There are lot of risk factors which like I have discussed in my lecture, like estrogen therapies and the chromosomal aberrations like Klinefelter syndrome, and sometimes so all these factors are, sometimes, and importantly, sometimes we do not have any high risk factors, and still a person unfortunately develops a male breast cancer. So everyone has a male breast, and I hope I
Yes,
answered
yeah,
your
that very
question.
well answers his question.
Uh,
Also, Yukta Mahajan is also thanking you, ma'am.
yeah, most welcome, most welcome.
So
Yeah.
I take over from here. Thank you so much, Rachna. It's been almost 1 hour, and I think I'm sure Umisha joins me and Tehzeeb that we actually did not even come to know that it's almost 1 hour till the time
Indeed,
Same
indeed.
Dr.
here,
Sameer
same here. It
started
was
to
wonderful.
show in. And so before we welcome Dr. Sameer, I would like to introduce Vivekananda Institute of Professional Studies to both of you, Dr. Rachna and Dr. Sameer. And we just hope that the emergency for which Dr. Vikas had to rush, it goes fares well, and we are with the patient. Vivekananda Institute of Professional Studies was laid in 2000 as a part of Strength India Society, which is basically standing for acronyms STRENGTH, signifying Society for the Revival of National Glory and True Heritage, under the founder chairman, Dr. S.C. Watts. We are affiliated to Guru Gobind Singh Indraprastha University, recognized by Bar Council of India, approved by All India Council of Technical Education, and NBA accredited for MCA program. WIPS has earned an A grade by NAC and is recognized by UGC under Section 2F. We have 12 courses and have collaborated with MHRD initiatives for quality education. What you see today, Dr. Rachna and Dr. Sameer, is basically two set of volunteers from this pool, the National Social Service Volunteers and the Gender Champions, all of whom have placed society before self, as I always give them a pat on their back. I also feel privileged to have a brilliant faculty team heading these societies, Ms. Tehzeeb Fatma, who has very closely interacted with both of you, Dr. Sunil Mishra and Dr. Anshu Gagal, all of whom have really helped us make this event possible by contacting both of you. And you, thank you so much, both of you, for enabling us to conduct this event. These students and you all are indeed a role model for generations to come. So over to you, Dr. Rachna, if you had a word to say. I think I kind of stopped you in between.
Yeah, thank you so much for inviting me. It has been a wonderful association, and look forward to many more such opportunities. So I would like to leave, though I would have loved to listen Dr. Sameer's lecture, but actually I have to rush for my evening OPD. And probably we have a recording, and I can, have the pleasure of listening to it.
Sure.
Definitely, ma'am.
So good day and goodbye. Thank you so
And
much.
thank you so much, ma'am. Thank you so much.
Rachna ma'am, can you stay for a minute?
Yeah. Hello. How are you?
I'm good. So, hi everybody. Sameer Badlani. So, pleasure being here. I got to catch the last 5 minutes. I just posted the risk factors for male breast cancer on the chat. So, if anybody's interested, before we get started, I don't know how many of you know that Shilpa, Rachna, and I went to the same school. And for the record, both of them used to trouble me a lot. I was a very shy boy, and I used to get hazed by both of them. So today is a little bit of a payback time that I'm going to take advantage of.
You're most welcome, Sameer. Rachna, please carry on. Okay.
Rachna was the smart one. I was always like number 3 or number 4. So for the record, Rachna was the topper in our class.
Okay. Thank you so much for the introduction.
I'm going to tell more stuff. You might want to stick around, Rachna. So I have a whole list of stuff about you that I've written up.
Don't open this up here. And we are getting a proper introduction.
But it's good to see both of you, Shilpa and Sameer. It's good to we could connect, with this noble cause of spreading spreading.
Yeah, absolutely.
Thanks to
That's
students.
the most important thing.
Yeah, yeah, yeah.
So,
So-
Samir, I think you should continue with the lecture, and I would love to, listen and laugh, because you have an amazing sense of humor, and so I have to leave for my evening OPD, and I'll
Yeah,
catch you.
of course.
Okay? Yeah.
Yeah.
Bye bye. Yeah.
Take
bye.
care.
Yeah. Thank you.
All right, Shilpa.
So,
Sorry, I
Dr.
couldn't resist.
Sameer, yeah, please. Dr. Sameer Badlani received the University of Oklahoma. He also received training in biomedical informatics, wherein biomedical data is used for problem solving and decision making, motivated by efforts to improve human health. Currently, Dr. Badlani is heading the Fairview Health Services at Minneapolis, which is a nonprofit academic health system. His experience as a clinician and IT executive enables him to provide and consistently improve upon the safe, high quality, and efficient clinical care operations and delivery. On behalf of the Institute and my team, I extend a very warm welcome to you. And wow, that's beautiful. So that's Sameer's morning today.
Thank you.
Thank you, dear students. Over to you, Dr. Sameer, please.
Thank you, Shilpa. Thank you, Tehzeeb, for this opportunity. And thanks to all of you for spending some time listening to me as I share my thoughts. So as Shilpa said, I got my med school degree from Delhi University, and I worked at AIMS for a couple of years, and then went to the US and got an informatics fellowship from the University of Utah, did my internal medicine residency, which in many ways is equal to the MD here at University of Oklahoma, and became faculty at University of Chicago for about a decade, where I taught at the med school and the residency program. And my clinical practice was mostly solid organ tumors and transplant medicine in the inpatient side. I did not have an OPD as many doctors do. Subsequently, I moved on to more corporate roles in healthcare and became the chief medical information officer. Think of it like the use of technology and data analytics in healthcare delivery. It's a fascinating field that I was very lucky to get exposed to 20 years ago and have been able to build a career. So it's been a lot of fun. And Shilpa is very kind to say that I run Fairview Health System. My boss wouldn't be happy to hear that. I'm still number 2. Which is just fine. It gives me a lot of time to do things that I enjoy doing, like spending time with people on calls like this and sharing my thoughts. My role is right now the Chief Digital Information Officer, and roughly translates into I have areas like enterprise marketing, core IT, data analytics, medical informatics, and digital transformation of healthcare in my portfolio. And I don't practice actively in the sense I still have a medical license, but what has happened through social media channels like WhatsApp and others, I have the benefit of helping friends, family, their friends and family. So now when somebody says, do you practice? I say, yeah, I have a global virtual concierge medical practice. I don't charge anything for it except good wishes and goodwill. Occasionally, I get a nice bottle of Japanese scotch, which I never say no to. So it works out for me. All right. So the topic that Tehzeeb and Shilpa asked me to speak to, since you've already had an expert like Rachna speak about breast cancer per se, therapy and risk factors, is more around the patient, the psychological effects, and what does a patient go through. I can tell you that, one of the other things that I forgot to add in my biography is that when I was at AIMS, I used to work at their cancer hospital under Dr. Kochu Pillai in the 2000s. So that was a wonderful experience as well. And I got to, have the honor of participating in the care of many patients. So let me start, the way I have divided up my thoughts is I'm going to speak about the patient first, the primary caregiver, and the extended family. The interesting thing about cancer, and I'm also going to keep giving you books and websites to look and read if you are so interested. So the most famous book on cancer right now is The Emperor of Maladies. It's quite a thick book, but I highly recommend you read it. It's by an American author of Indian origin, and you will get a real good sense about cancer. what I found about cancer, not just in India and US, the two countries that I've had to practice medicine, there's a lot of myth about it. There is a lot of perceptions about it. And when somebody gets a diagnosis of cancer, or you want to talk about cancer, I don't know if you guys have experienced this in your dealings, everybody just goes quiet, and nobody wants to have conversation. There is this, you know, just almost like a panic attack falls over the entire conversation, and people feel like, it's a topic that they just don't know how to react to, is my best way to describe it. And I found that very interesting, observing it. Now, when a patient suspects or gets cancer, often what happens is that uh, people just assume it's an automatic death sentence, and your life is over, and there is nothing else that's going to be available to you, or you pretty much should hang up everything and go to Banaras and find a little kutia there or something like that. That's literally the level of reaction that I see in the Indian society, which is very unfortunate. The good thing is there are many cancers now that get completely treated. There are cancers that have very little treatment, and yes, truly are, you get a clock against your name and you're running down that clock. And in the middle, there are many cancers that have different ebbs and flows, and it really depends on what stage and what kind of variety there is. So if you stick to breast cancer, there are many breast cancers that are completely curable, especially the ones that have the right kind of hormone profile. So estrogen positive, progesterone negative, and Herceptin positive. If you have something like that and it's got caught at a lump stage, then a very simple surgery called lumpectomy, chemotherapy, some chemotherapy, and radiation, really you can have 100 percent survival rate in many of these cases. On the flip side, I don't know if Shilpa and Rachna shared with you guys, we lost a classmate by the name of Jasleen a couple of years ago, who unfortunately had new cancer diagnosis with undifferentiated tissue, and it just, within 6 months took over her life, and unfortunately she passed away. So that's an example of, where, there is no therapy yet right now, but a lot of research being done, a lot of opportunities are there. So what I like to tell people is, once you get a diagnosis of cancer, let's first take a pause and understand what exactly it is, what size it is, where is it, and how can we figure out how to treat it. The reason I find the reaction of people to cancer very intriguing, and just not the patient, but the family and everybody else, is there are so many diagnoses in healthcare that have very similar lifespan limitations. So if you have congestive heart failure, stage 3, then you have about 3 to 5 years to live. If you have really bad COPD, not asthma, this is different, where somebody has been a smoker all their life, and now the lungs are completely full of emphysema, you probably have another 3 to 4 years to live, if that, and then you also have to be on oxygen. That's again 3 to 5 years of lifespan or something like that. Or if you have kidney failure or any diseases that I had to see and other people see. But it's cancer that somehow brings out this complex human emotion that I think is very interesting and worth talking about a little bit. So the first thing that a cancer patient experiences is absolute denial in general, that this is not happening. There must be something wrong. And I would recommend, there is a professor by the name of Bridges. He was a change management professor that some of you may have read, nothing to do with medicine in this case. But the Bridges theory of transitions is an interesting concept, where what he talks about, or did talk about many years ago, is that when you get a bad news, everybody goes through, 4 or 5 stages of change. And Kubler-Ross is another example of the 5 stages of grief as they talk about it. So if anybody's interested, not just for this particular case, but anything else in life, it's important to look at those stages. And they're all similar, but basically what they start with is, the first is denial. You actually just don't want to accept that, anything like this could be happening. In my case, I started losing my hair at the age of 18, and probably only 3 years ago, I finally admitted to myself I don't have much hair left. So, perfect example of a human being can, convince yourself of almost anything. And so similarly, a cancer patient will go through a lot of denial. This is not happening. So in India, we have doctor shopping. We will go to 15 doctors, and it's not just in cancer. It's for your skin affliction. It's for your diabetes. You will go to 15 other people till you find the answer you're looking for. I see that in diabetes a lot. Till you find a doctor who says, no, you don't need medicines. I can cure this with Ayurveda or homeopathy. You're like, he's a good one. And then you try to go to your family and push that doctor on all your friends also. That's also like a social responsibility we Indians have, is mere ko acha mila hai to dusre ko bhi dunga zarur. So you go through the denial phase, and then you really get into anger. And I think we should spend a few minutes talking about the anger phase of a cancer patient's journey. The anger goes into two parts. What did I do wrong that this is happening to me? So you start going through your life history. And the challenge is, in most cancers, we just can't point out you did X thing wrong. So like in heart attack or diabetes, I can generally say that, look, you are obese, you didn't exercise, your diet is too carb rich, you drink too much alcohol. All these things add up, and is an example of, this probably added to your risk factors. Cardiovascular disease, if you look up the Framingham score online, you can put in your age, your blood pressure, your cholesterol, and it'll give you a sense of what your 10-year risk is. It will show 5%, 10%, and so on and on. But in cancer, many cancers, we can actually pinpoint what went wrong. In some cancers, we can't. There are, chemical exposures, radiation exposures, high alcohol intake, you can say. But in breast cancer, it's multifactorial. Now, interestingly, there are some, groups of human beings, especially the Ashkenazi Jews in the United States. So it's a group of Jews who migrated and stay with each other and come from a very specific part of Eastern Europe. We find they have an amazingly high rate of breast cancer. So there, the scientists were able to do some genome sequencing, and they found that there are genome groups called BRCA1 and BRCA2, BRCA1 and 2. So if people have those two, both gene compounds in them, then they have tremendously high risk. So yes, in that case, in the most extreme cases, you do, you remove the breast tissues and the ovaries both in a way to reduce the hormone exposure in the body, and you can do it. Then I think most of you may have heard of the HPV vaccine that has become available over the last 5-6 years to be given to women, and in some cases boys as well, in their early teens, that reduces the risk of certain kinds of squamous cell cancers later on. So in few cases you can, but in most cases you can't. And I find interesting conversations with patients who say, I ate something 3 years ago on a trip to XYZ place, and ever since that day I haven't felt well. They try to pinpoint that event in their life and say that this is what happened. And what I realized is I try not to argue back much. I just try to not say, no, you are wrong. I don't say that. What I say is, well, let me tell you what science tells me and what I know about the risk of breast cancer and other such situations. Because no matter how much facts I put in front of somebody, they're still going to hold on to what allows them to rationalize what's happening with them. And that's what we have to understand. We are not going through it. They are going through it, number one. And you just have to give them time, space to get through it. But we have to make sure we don't reinforce any of the things that cause a person to start thinking like that or believing like that. So, my own mother is a breast cancer survivor, and her diagnosis happened in, 2008, I want to say. And it was interesting. She had a lump in her 30s, which she immediately went for testing. And, it was taken out. It was just, a fibrotic cyst and nothing to do there. So when she got a lump again, in her mind, she did two things, which I will tell you is an example of what most patients do, is to say, well, I had this before, the lump, so it must not be cancer. Or they will say that, I'm just going to pray harder. So, this whole thing of that I can pray things away or that there will be a miracle for me because I'm just such a good human being. Whether you're a good Muslim, Hindu, Christian, whatever you want to pick, somehow that's going to give me extra thing. Unfortunately, it doesn't happen. So I'm sorry to disappoint those of you who were hoping for that answer. So she delayed it, and she waited 9 months, and the cancer that was probably this small became the size of my fist. So what that did was that delayed diagnosis caused the cancer to spread. And instead of being a very simple lump surgery, like I told you about, she had to go through a big surgery and a lot more radiation, a lot more chemotherapy. That was more suffering for her at the end of the day, and my father as the primary caregiver. And if you look at the tables that talk about survival rates, so most cancer rates, if you look at the survival rates, they're either broken down into a 3-year survival rate if it is a very aggressive type of cancer, or it will be in the 5 to 7-year survival rate. So in her case, she went from 100% to 65% survival rate. So what that means is if there were 100 patients like her who had locally advanced disease, which is what her diagnosis became, only 65 of them would survive. So she's one of the lucky ones that, she still survived, but at a tremendous cost to her own health, mentally, physically, and emotionally. And she was very lucky that she had Herceptin hormone positive. So just in the last 10, 15 years, a new chemotherapy drug called Herceptin has become available. And if you are Herceptin positive, it's a directed therapy rather than sort of a broad-based therapy. And, you get lucky. So this thing of denial, when you first see the symptoms, goes two ways. Some people will run to the doctor, every 15 days and say, I have this, they start showing things to you. Shilpa and I have another classmate, I won't take the gentleman's name, who literally every 15 days thinks something is wrong with him. So whether it's his heart or his liver or something, we jokingly call him Chintamani. And, that's, more high school stuff. But the reality is the human psychology can be anything. You can have people who are in complete denial, people who are sort of in the middle and do the right thing generally, and people who are very hypochondriac. Nonetheless, cancer is something that we should get screening on a regular basis. And, there is a website called knowyourlemons.org. I will post it on the chat momentarily when we are in the question stage, and I can stop talking for a bit, which you guys should look at. It's a very impressive campaign that is now a global campaign that educates people about how to do self-examination of breast and different kinds of breast tissue, and what is high risk of cancer and what is not high risk of cancer. And that's the best thing that a woman can do, is do self-examination. I would encourage men to also look at it, because male breast cancer is uncommon, but not that uncommon. Everybody has breast tissue. Whether you're fat, thin, whatever, you may have a small, you may have slightly big. And as I posted on the chat, the risk factors are mostly around, age, alcohol use, and, radiation exposure, and anything that causes hormonal imbalance. So in some cases, it could be hormonal therapy. In some cases, you drink so much alcohol that your liver is messed up, and so on and on. Anyhow, so I think helping a patient get through the denial phase is very important, because after denial comes anger. You start lashing out at everybody in front of you, and you feel like life has been unfair to you. And I've seen it in a lot of my patients. I've seen it in my family. I've seen it in my extended family. They look at any bad events, that may have happened. You hear things like, I never had happiness in my life, so this happened. Or, well, if you're in India, my mother-in-law was very mean to me, so that's why I carry, pain in my heart, and this is why it happened. Or, in my case, my mother said, you went to America, you're a bad son, and that's why I got it. So, as much as it hurts to hear those things from your own parent, you have to realize they're in a very tough place right now, and they don't really mean those things. But, and it's not that I was able to brush it away. It took me a few months to not stop thinking about that. So you just have to understand, the patient is going through a lot. So the fear and the denial thing are real. They will come and go. And the fear comes from, two places. One, am I going to die? Well, let me tell you guys something you may not have heard. We're all going to die. That's just the day we are born, the only reality and guarantee in our life is we're all going to die. There's no reason to be morose about it. Bhutan is a very interesting culture. I suggest you guys read about it. And they, in their culture, talk about death every day. So they talk about that, okay, if I die, how will things work? If I die, I wish for this or that. So when you talk about death in a matter of fact as something that's an inevitability, it becomes easier. The fear is less. You deal with it on a daily basis. Somebody may be completely healthy, but and the neighbor might have some really bad cancer, but the person who's healthy may have an accident tomorrow. But the person who had cancer just kept thinking all day long, I'm going to die, I'm going to die. You view the life from the lens of I'm going to die, I'm going to die. Well, you're shortchanging yourself and everybody around you. So the fear comes from fear of death, and then the fear of recurrence. Patients who are on the remission side, obviously get checked up, and then they worry about just is it going to come back. So it brings out a lot of emotions. The next sort of complex of emotions or experiences are pain and fatigue. Cancer patients definitely experience a lot more pain than the average human being. This is real. They experience a lot more fatigue than what you and I can imagine about. And think of the day where you were totally tired, you just did not do anything, but somehow everything, whatever happened, you're really fatigued. Now multiply that by 5x. That's how these patients feel almost on a daily basis, especially during the chemotherapy phase. So, things like saying, buck up, just let's do it, may be good 1 or 2 times, but you have to understand, they're really pushing themselves, and it's good to push themselves. So really trying to understand, how do you talk about understand pain and fatigue, and really understand that for a cancer patient it's non-trivial, and our goal is to support that particular complex. The third thing that when patients get through the initial anger and denial phase and are in the acceptance phase, there's another interesting emotion that you may have seen that comes guilt, which is, can come from that, oh, what did I do wrong? Now it's not the world didn't do anything wrong, I did something wrong, or I should have drank more hot water with lemon in the morning, whatever your family's favorite hype is in ginger water, that water, and or I should have not done this, or maybe I'm a sinner. That's the other thing, that in our Indian ecosystem and many other ecosystem comes in, where we think that this is a function of my bad deeds in this life, or I love the fact that we still talk about previous life as if it's a guaranteed thing, and that somehow has caused me to get cancer. I'm not learned enough to argue against that or for that, but what I will tell you is that it's an unhealthy thing to think about, that somehow I gave this to myself. Yeah, if you were smoking a lot, if you were really obese and you messed up your liver and that led to some disease or cancer, sure, you did it to yourself in some ways, but it's not that straightforward. Nobody likes to do anything like this. And so the guilt and the blame complex go together. You try to feel it, blame yourself, blame your family, blame your friends, and it sort of it's an interesting emotion, because the people feel that I don't know, it gives them something to hang on to, something to focus their emotions on, because focusing on I have to now go through 6 rounds of chemotherapy, it will be a lot of struggle and challenges. Those are difficult emotions for somebody to go to. The next one I'll speak about is social issues. And for me, I find that very challenging. It's one thing for the patient to go through what they're going and go through that emotion. There's a little bit of justification I feel, I can extend to them. But we as a society, I'll just tell you, do a piss poor job of supporting our patients and family members with cancer. It's almost like we think I did something right, you did something wrong, that's why you have cancer. I'm a vegetarian, this guy's a non-vegetarian. I don't drink alcohol, you drink alcohol. I pray to the right God, you pray to the wrong God. Literally, we laugh about these things, but trust me, in our own families, there are people who think like that. These days, obviously, I won't get COVID because I do pranayam in the morning and I have high immunity. So good luck. really, they go through these kinds of things. So our goal as the social circle of people who may have cancer is to be supportive and is to listen. It's the role of the doctor and the care team to provide medical advice. Our goal is to listen to understand versus listen to respond. So I'll say it again: listen to understand versus listen to respond. And I find that, when people say, "Oh, I had a really rough day," uh, and I just want to lie down, they're like, no, 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 here I got this special dish that I cooked for you, and it helped my mama ji 10 years ago, so it's definitely going to help you, or something like that. So you get all those, and you're all trying to help. It's coming from a good place, but it's very misplaced. That's the challenge. Someday the patient might just want to be alone, read a book and go for a walk, or just think, stop and think. And we just don't give them that space. We feel that if I leave them alone, I'm doing them a disservice. So really learning to say, what does this person want, and not trying to course correct that person to what we think our values are. I'll give you an example. I have had patients who are 76, 78 years old with terminal cancer, and the daughter came to me and said, I'm just so flabbergasted. I said, what happened? She said, my dad still wants to smoke, and he has lung cancer. I said, okay, so what's the problem? She said, but this is what gave him the cancer. I said, yeah, but he's not getting better, right? You do know that. So if the dude wants to smoke for the last 16 weeks of life, I'll buy him a cigarette packet. What's the problem here? So life is not a punishment. Uh, you know, I remember, I had the privilege of helping my wife's grandmother in her last few days. She didn't have any particular disease except diabetes and all that. And as she was coming towards the end, her blood sugars started dropping, and we took her off almost every diabetic medicine. And then I get a frantic call. She wants to eat ice cream. I'm like, she's 86 years old. She wants to eat ice cream all day. Give her ice cream all day. What are you trying to do to her? So let's keep life in perspective here. For a 46-year-old with bad diabetes to eat ice cream, yes, I'll get on the phone and chew them out. But, an 89-year-old just wanting to have ice cream, even if, it's bad for them, why do you want to talk about it? So really think of a cancer person's journey as from a quality of life perspective. So when we say, okay, you have these treatments that can be given to you, what I try to tell anybody is, you as a patient have the right to decide, do you want to go through this or not? So if a patient who has a curable cancer says, no, I don't want to go through the pain, the radiation, the surgery that comes with this, and I will just deal with whatever comes my way, as long as they are of sound mind and have thought this through, it is our responsibility as caregivers and family members to respect that. And what I find very challenging in India is half of the time we don't even tell the patient. And this is not something that happened 20 years ago when I used to still live in India. I'm talking about 6 months ago, when another classmate of ours, sorry, we have very interesting classmates. The mother-in-law has cancer. And I'm like, have you told Amma about it? They're like, no, we're going to tell her in a month. So the person who has cancer doesn't know. Everybody in the family knows the person has cancer. I am somebody she's never met in her life, living like 3,000 miles away. I know she has cancer. So in at least the US way of thinking, that is actually a violation of a patient's privacy and rights. I personally think, whatever you may think that your father or your mother is incapable of handling the truth, that's not your place to decide that. The patient has to be told everything before anybody else knows. We actually see this in Hispanic culture as well, especially for the mother of the family. They will not tell the mother the bad thing. The son or the daughter will want to know. And because there is a language barrier in many cases of the mother only knowing Spanish, having recently migrated, the English speaking person will hold all the information. And I've had situations where I'm standing in the room. I'm like, no, tell it to them. I know enough words of Spanish to know whether you told the truth to that person or not. And just getting the family to tell the person the truth. They deserve to know the truth. It is they who are going through it. The rest of us are not going through it. So that's, some of the challenges that we speak about. And then the social stigma. I think it's important to talk about that as well. Breast cancer is interesting in the sense that a lot of patients lose their hair. uh, as you know, through the chemotherapy. Now, there are better, well, not better, but different drugs that have much reduced risk of hair loss. Um, and there are hospitals, at least I know of many here. I don't know how much of that happens in India, where they proactively will set you up with a wig before you start a chemotherapy. Imagine having to go look for a wig when you're already going through chemotherapy and throwing up and losing your hair. So this is something here we do before you go through chemotherapy and get a wig. If you're getting surgery where breast tissue is being removed, then they already set you up with a bra that has padding on one side, or set you up with a plastic surgeon once you are cancer free, should you desire that. So all those things that you and I may think are trivial, that why would you care about these outwardly appearances when you are now surviving from cancer? That's fallacy. Human beings by definition are vain, whether we want to accept it or not. And the way our mind is, that how we look to ourselves has a very important input to us. So why do we wear nice clothes, or why do we comb our hair, or if you have hair, why do we do many of these other things? It's a very basic human need. So for us as family members to think, I can't believe my mother is worried about her hair when she has cancer, is outright not okay. So taking care of those things, can really help a patient. There are some chemotherapies where you can put ice packs on the head to reduce the blood supply to the hair, so that the cancer drug doesn't come there during the infusion. So many things you can do to help a patient feel a higher level of self-esteem and feel better, so that they can take care of themselves. Now, the social stigma side of it is, you see somebody with cancer, what do you do? If I was in a classroom, I would have, called on all the backbenchers and asked them to give an example, but we can't do that today. So we turn our eyes away. That's what we do. We look here and we look there. We try to make obvious small conversation on nonsensical topics. Why? Talk normally. Treat them as a human being. Don't bring up their cancer every time, but if they want to talk about their cancer, look them in their eyes and have a conversation about it. That's what you can do. Celebrate their birthdays, celebrate your birthdays, celebrate occasions. Yeah, you don't have to go nuts, but you don't, it's not a death sentence for every day for the rest of. They're still alive right now, so let's treat them that way. So that talks a lot about the patient. Then I'll go into something that I think is often missing to a very big degree in Indian culture, is the primary caregiver. So in my mother's case, it's my father who's the primary caregiver. And in somebody else's cases, it might be the parent, it might be the spouse, it might be one of the child, but there's always one primary caregiver. And studies have shown, really detailed sociological studies, that the emotion complex that a cancer patient goes through, the primary caregiver goes through almost the same level of it. So the depression, the anxiety, the fear, everything, you're almost parallel to it, because you're living with that person, you're dealing with it every day. And in our culture, it's like, well, I'm the husband, it's my job. She would have done it for me, or it's my father, he took care of me, now it's my turn to take care of them. So you just keep going through all of this. Now that's great that we are willing to be that supportive, but on the flight, what does a hostess say? Put the oxygen on yourself first before somebody else, right? So never has that been more true than a situation like this. And I can tell you, as many times I've had a conversation with my father that, hey, can you take a break? What do you do for yourself? And he looks at me as if like, I thought you were an intelligent son. What kind of a stupid question is that? Just the concept that the primary caregiver needs a break, the primary caregiver can feel all these things, is just like, when you talk about it, it's like you're almost, engaging in blasphemy. That's what you are doing when it comes around. So that can cause the primary caregiver to go through their own set of psychosocial, emotional, physical diseases. Stress is definitely known to be a risk factor in cardiovascular disease for sure. and you will see that play out in many cases. Their own mood swings, their own unhappiness quotient, all of those things will light up. So the first thing is that as if you're a primary caregiver of a cancer patient, acknowledge that you are the primary caregiver of that cancer patient. Reach out to family and friends to help. Make the cancer patient understand slowly over time, not on day one, that you will need to take breaks, and there is nothing wrong with that. And it will be better for them, that if you take breaks, because when you are taking breaks and self-healing and you come back, you will be a better caregiver to that person. And I see this in so many cases where that relationship becomes a very pathological codependency relationship. I have to take care of X is like, you have to take care of me, and like you forget that the person in front of you is a human being and also gets tired and other things. And these are not easy things to talk about, so none of what I'm talking about today is like a 30-minute conversation with known to who has cancer. These are things you do. So simple things like, if X person is the primary caregiver, then you just show up one day and say, hey, dad, why don't you go for a walk, or with your friends, I'll just hang out with mom for the next 4 hours, and you just like send him out of the house. Now, I've never been able to do that except for 15 minutes, but you have to try. If you reach out to friends, you reach out to family, and you spend more time and allow that other person to take a complete break and do what they want to do. So really understanding the fatigue that comes with being a primary caregiver, it can go on for years. It's a non-trivial amount of effort and emotional pull that you're putting. A lot of these things create financial stress. So, what we don't realize is going through a cancer diagnosis, often causes people to drop out of their employment or go into, partial employment. So many other things that, start getting in the way that you have to think about. So I know I've been speaking a lot. I will just very quickly share a few resources. So one of the things to understand is, when you get a cancer diagnosis, besides this emotional thing, I feel the information gap is just insane. Whether it's India or US, you go to your doctor, you get good 15, 30 minutes, if that, and they're focused on that point of your care at that point. You have 27 questions. Why, how, where, what's next? I had, this pain here. What about that? Or, is my family at risk, and those kinds. So unfortunately, our healthcare systems are not designed to respond to that need. And if you do a survey of cancer patients and their families, you will find that is shown to be one of the the biggest frustration that they talk about is the information gap. So, there's a website called breastcancer.org that you guys should look up. And in US, there was a startup, well, we call it a startup, but what it was, realizing that you go through all this without much information. And if you're the only one that has, breast cancer in the extended family, then no matter how nice the other people are, they just don't really understand what you're going through and what your needs are. I mean, as much as you try, that's the reality. So there is a website called Patients Like Me. Now, unfortunately, over time, it's become a little commercialized and has become sort of a, way to catch data from patients and monetize it. But still, communities, online communities like Patients Like Me is a wonderful resource where you can literally go and say, I have this kind of irritable bowel disease, this variant, and suddenly you realize there are 50 patients, like me, and that allows you to talk in context, and it's very powerful. So, what I found, really troubling, deeply emotionally troubling, is when our friend Jasleen passed away, and I was visiting from US and I went to visit her. I saw the isolation she was going through, even though she was living in a joint family of people just didn't understand what it is to be her right now. And very simple thing. She pulled me aside. She always was a very conservative girl. Every time I would put a double meaning joke on the group, I would get a scolding from her. So, she pulled me aside and she said, Samir, I need to ask you something. And I was like, yes, what? She said, I really need to get a proper padded bra. I said, okay, so we'll get you one. What's the big deal here? And I realized that it was something she felt uncomfortable talking about in front of her own husband, her own mother-in-law and family. And I said, did you not tell them? They're like, yeah, but they don't understand. And to me, that was heartbreaking. That, forget chemotherapy and everything like that. Something as small as what she needed for her comfort. She had just gotten surgery that was so difficult for her to bring up. And, in that moment, almost everything that I have written up today to speak to you gets captured. The isolation, the depression, the anxiety. So that's what we have to really think about. And, who else would understand what she's going through? Another patient who has breast cancer. They'll be like, yeah, I got this. I can help you figure it out. So, we helped her, but to feel that people don't understand what I'm going through and I have to ask is not a nice situation to be in any means. So those are things that we have to think about. A lot of patients who go through cancer therapy have trouble doing activity of daily living. So that's a term we use here, ADLs, which basically you can think of as self-care. Being able to bathe yourself, use the restroom, clean yourself, shave if you are a guy. Well, that's why I keep a beard. I don't have to shave every day. It's the best thing I ever did. So, it's those are things that you have specialized physical therapy. And I know now in India, you can get good physical therapy, but 20 years ago, it was like, you better have had a spine accident that you'll probably get access to that. So those kinds of things, really help. Nutrition. Unfortunately, our notions about nutrition are very misplaced. That non-veg food is bad, vegetarian food is good. It's nothing like that. Within non-vegetarian food and vegetarian food, there are good foods and bad foods. Eat a potato every day, and you pretty much are killing yourself. I often tell my friends, and they don't like hearing it, that eating rice and potatoes, you might as well eat a gulab jamun. You'll get more emotional happiness and save amount of sugar in your body. So those are kinds of things that they have to talk about. So then personal image, we spoke about prosthetics like padded bras or plastic surgery, scar removal, hair when it's needed. And I'll tell you, it's interesting, my mother's hair went away, and boy, that was the main thing she was upset about. You can make whatever judgments you want. Here's a lady who might die, is worried about her hair, and I can tell you all of us are like that, all of us. And now when I go back and see her, the first thing she says is, "Mere baal kaise lag rahe hain?" And I literally have to go, what did you just ask me? I thought she would ask me about her diabetes or other things she's going through. She says, "Baal kaise lag rahe hain?" Well, that's what is important to her. The final thing I'll say is post-traumatic stress disorder. So I would read up on PTSD as much as you can. Normally, we speak about it in cases of, soldiers coming back from the war or people exposed to tremendous amount of physical, emotional, or sexual abuse at some point in their life. That's also real for breast cancer patients. So for me to go back and now tell my mother, I can't believe you're talking about your hair. You're lucky to have survived cancer. That's me missing, the boat here. She has PTSD, hands down. So when we are willing to take a person for chemotherapy and radiation and physical therapy, why are we not willing to take them for PTSD or other psychiatric, psychological issues to a trained cognitive behavior therapist or a psychologist who specializes in that. So I would say that as much time as you spend researching the oncologist, the surgeon for a loved one who goes through this, take the time to think about a behavioral therapist and other kinds of experts who can help, not just for the patient. Maybe if you're the primary caregiver, find a group of primary caregivers, people like you who are helping somebody with a loved one with cancer. The support you can get from them, you can't get from even your best friend. Because context in everything is important. So I'll stop there. I know we're almost at the end of our time, and I'm happy to answer any questions. Stuti, yeah, you
We're
can read the
really
book.
grateful.
Rachna,
So,
before you open up for questions and just to kind of, tweak each one of you, you've always seen me as somebody who's been all ears to all of you, my young boys and girls here. I have also done something similar to what Samir just said should not be done. And I really want to admit it here. So my dad, as you're aware, was also suffering from multiple myeloma. And there have been occasions like I had never seen like any daughter seen that tiger falling so rapidly. And I saw, and I used to keep on bothering Samir all the time and used to tell me, you let him chill. So I also went on to that denial mode. And when the doctor told me that it's just a matter of 3 weeks, I do not know what psychological sync went inside me. And it was like my daddy's strongest. And I used to feel that of course it cannot happen to my dad. And I did not share it with him that it's a matter of 3 weeks. I did not even share it with myself, despite the fact that I had heard it. So to all of you out there, I really want to tell you that when you speak about Shilpa ma'am and you think that big room, big office, she's as minuscule as possibly any one of us. So don't ever as Samir has pushed me to tell you this, that don't ever get into a denial mode and let it be what it is. I mean, let the world feel what they want to feel about you. But guys, go ahead and ask your questions. Over to you, Misha.
Yeah. Before as you guys ask your questions, I'll tell you something. I was watching a show recently, and what else will you do these days? You can't, fly off to Spain and Italy as I would do on vacation, or come to India and meet my parents and then go to all my favorite kebab places. That's all I do when I come to India. I was watching this show about where a guy repaired an old violin, and I hope to be able to do something like that myself. And my daughter, who's 7 years old, was playing the piano, and I thought to myself, the day I'm dying, I would want her to play the piano for me. And the reason I'm sharing this with you guys is, imagine I have cancer and my daughter doesn't tell me, or my family doesn't tell me that I have 3 weeks left. If you tell me I have 3 weeks left, I'm going to have my daughter play the piano for me. I'm going to eat all the kebabs I can till I start throwing up. And I'm going to finish out all my Japanese scotch. I deserve that decision making in my life, and so do you. So, we do things out of love, and we do things in life as if it's some game. You guys are still very young, and I can tell you one of the challenges. And I wish Rachna was on the call. She was the smartest person in our class, and I think she still works 18 hours a day. And I still tell her, why are you working 18 hours a day? Do you not have enough money? I know that's not the case. But she just likes to work. And the biggest thing I can leave all of you is take a step back and do what is important to you. And I can guarantee, I'll bet my best Japanese bottle of scotch with all of you, 99% of you don't even know what is important to you. Because you have been running after titles, money, and whatever you think your parents, society, friends expect from you. You don't know what is important to you. It's taken me 20 years to figure out what's important to me. And that will again change in 20 years. So you deserve to give yourself a break. Now, I understand that I'm very privileged. I'm very lucky. I'm not trying to be facetiously humble that, oh, this guy's a doctor, so he's called. No, I am very lucky. When I got through med school, there were 40,000 people who applied in PMT. That I got a rank of 144 is luck. And I can actually scientifically prove that to you, because that year chemistry was easy and physics was hard. And I was good at physics, so I got in. If I had given the exam 1 year before, I would have not even been in the first 1,000, because chemistry would have wiped me out. Luck. So yes, you have to earn a living, you have to take care of your family, but at some point you have to pause and say, I am running so fast, I don't even know why I'm running anymore. I don't know, are you stopping and smelling the roses literally? So those are things that you really have to take a pause and say, what does smelling the roses mean to you? In my case, it actually means growing a rose. So that's what I do. It forces me to slow down and learn patience and succeed and fail and spend time with my daughter. I'm a late father, so I, hold on to that as much as I can. So I would urge you guys, I appreciate all this conversation, and I hope you never get cancer, but and neither do your loved ones. but let's not wait to get cancer before we realize the value of life. That's the last thing I'll say. All right. Now
Certainly don't want this conversation to end, by the way, but yeah, moving forward, sir, your words were not just informative, but so emotionally enriching. Moving to the questions, we have Kashish Gupta with us, who is saying that thanks a lot, sir. Absolutely loved how you got into the conversation with the aspect of mental health and empathy. What would you say should the way be for someone who struggles with hypochondria and health anxiety? Any advice or input would help.
You know, that's a pretty long conversation. The short answer to that would be, first of all, to accept that you have hypochondria. I think if the person is not going to accept that, then you pretty much can't do anything. The second thing is to seek out a therapist, because most of these things come from some other deep-rooted emotion, insecurity, and in many cases, that hypochondria comes from because that person actually has gone through a lot more health issues than you and I may have. So, you know, our good friend Chintamani, I won't tell his real name, he does go through a lot of health issues. But what that has done to him is that it has created this psyche where he has to really worry about things. But now he worries about things that are just crazy. Every 3 days, he'll post, vaccine aaya kya? I'm like, bhai tu mask pehen yaar, vaccine ka kya karega tu? So that's the reality of it. So, the thing is to not trivialize it. It's not something you can meditate away or willpower away, or, pray to the right Baba or eat the right biscuit and it will go away, or wear the right, tabiz or necklace or ring. I love the ring concept. Ye wala ring color pehno, wo pehno, ye ho jayega, wo ho jayega. What a business. So none of those things help. It's acknowledgement, and then it's also seeking out the root cause of it. And it could be emotional, psychological, and actual really health issues. And then just trying to, work your way back from it. It's like the fear of heights. It's the fear of closed spaces. It takes time, and you will never get to a level of normalcy, whatever normal means in this world. I've never figured out that concept as well. What is normal? So that's how I would answer that question.
Thank you for your answer, sir. Moving forward, we have Divyam Sharma, and I think Dr. Badlani, you are the best person to answer this. He's
I am the
asking
best person, that I know.
He's asking that considering the privacy around healthcare data, how is data effectively used in healthcare industry without invading the privacy of patients?
So I would recommend, a good question. I would recommend you read the HIPAA laws, HIPAA in US, Health Information Privacy and Portability Act. It's an insane amount. If you're a law student, it's like the best reading for you. It's like 90,000 pages of privacy laws. But the basic concept is that if there is a group of elements within your data that I can use to identify this is Shilpa Khatri, then I cannot share it unless there's a health reason or without her explicit permission. So in India, you know how on WhatsApp, suddenly you will see that Sharma auntie in B block now has COVID. In USA, that would get you to jail. Because you absolutely have no right to know Sharma auntie has COVID in B block. Or somebody will get a lab report of some liver disease, and literally everybody in the family will forward it to 20,000 people in India. Arey, my mamaji's son has this. Does anybody know what this is? No, you can't do that.
WhatsApp University works good here.
Well, it's an amazing invasion of privacy. So in US, the laws are a bit too onerous, but when we do research or we look at, some sort of, opportunity to work on this, the idea actually is that we de-identify the data. So we remove the name, we remove other elements that can be identified. And if I am working, so I'm a provider organization, Fairview takes care of about 1 million patients a year. And my previous organization took care of 3 million patients a year. So if I'm giving a data set for any reason to somebody, they have to sign a business associate agreement and a data use agreement, which holds them to tremendous degree of liability and indemnification, so that if they lose the data or misuse the data, I don't go to jail, they go to jail. And in US, the fines can go up to millions of dollars for such mistakes and actually can get you into jail. So I would recommend you read the HIPPA Act.
Thank you, sir. I'm sure Divyam will definitely comply to that. Now, moving forward, we have Shikha Shrishti, who's asking that how can the primary caregiver or extended family help in keeping the morale of the patient high? Moreover, since sometimes people with cancer suffer from extreme anxiety and depression.
Yeah, I think that's a great question. First of all, that anxiety and depression need to be treated like its own disease set. You have to, and your oncologist, I can tell you, Rachna and the previous speaker are not, I'll tell them this on their face. Most oncologists in India are absolutely useless in providing emotional support. Just absolutely downright useless. I've worked with some of them, most of them. You shouldn't expect it out of them, honestly. At the end of the day, they should be nicer. I will tell them that on their face, but you still are looking for emotional support in the wrong place. So really finding out a good therapist, finding patients like me, other self-support groups for the primary caregiver and the patient, are meaningful things one can do to help with their morale. The other things one can do at home is keeping a bright environment. So one of the interesting things my mother does is she closes all the curtains and the room is dark. I'm like, kya kar rahe ho? And my dad pulled me aside and said, we bought new curtains. She wants to admire the pattern and then get adulation from everybody who comes in. Auntie ji, kya lagaya curtain aapne? Fine. My wife changes curtains. I don't even know they have been changed. And then I get into trouble that you don't notice anything, like all men. So, those are small things that you can do. Celebrate, that's another concept I would say. Celebrate small things. In India, especially, we are so in tune to celebrating only big events and big things and other stuff like that. We forget life is about small things. Big things is not about it. So really, spending time with them. If they want to, be in a bad mood and go through their 30 minutes of anxiety venting with you, let them do it. What I try to do with my mother is I will listen to her and then I will try to resize her mindset around what's going well in her life. So I'll tell her things like, look, of all the Masis, you're the only one not married to a jerk. Most of my Masers are total assholes. So, I'll tell that to her. I said, look, your sons are both, doing reasonably okay. They're not stuck at home and feeding off you. I said, look at, you have a new house. And I'll remember to, say, look, you have new curtains. And look, oh, that person is still not doing well and you are much better out of your cancer. So find the positive things in life. And I would encourage all of you to do it. We often focus on things that are wrong and not going well, and we absolutely forget what's going well and what's good in our life. So, really think about what is going well in their life and keep reinforcing it. So those are things that, will really make a difference. I do apologize. I have to, my work day has started. We start quite early here, so I have to jump off. But this was an absolute pleasure and my privilege to share my thoughts and ideas with all of you, and happy to do it on another topic some other time as well.
So thank you so much, Samir. I think before the vote of thanks, as a part of vote of thanks, Supreet, could we have your poetry? She had written a beautiful poetry, Samir. Just 2 more minutes, please.
Oh, thank you. I'm honored.
Certainly, ma'am. Good evening, sir. Before I start with my poetry, sir, I would really, really like to tell you that this is one of the most amazing webinars I've ever had on breast cancer or on any topic of awareness. And this poetry that I've written is also, it's not that personal to me, but the cause is pretty personal to me. So I really want to thank GC and NSS and my nodal officers and Shilpa ma'am for this opportunity. And just please pay heed to this for a couple more minutes.
Sure.
Suspected early or diagnosed late. A battle with cancer is a battle with fate. With 1 in 28 women diagnosed in India, breast cancer is increasing at an alarming rate. In male breast cancer cases, 1% of all cases fall. From patients to oncologists, breast cancer is a nightmare to all. A toxic journey filled with excruciating pain. October is all about stopping it from rising again. admiring the strength of the people that endured every bit. In fact, the word survivor hardly does justice to it. Furthermore, October is all about saving more lives, no matter of young boys or of elderly housewives. The Pink October leaves behind an appeal for diligent care and urges people to be cautious because a society secure is a society aware. Thank you, sir, and thank you, ma'am.
Thank you. That's wonderful poetry. Thank you so much. All right. You guys take care. Wear your masks. They do work above your nose. Wash your hands. Don't touch your eyes and maintain distance. That's the only thing that's going to help with COVID. You know, this, Ramdev ka biscuit and your favorite tabis and your favorite, pearl ring, none of those are going to work. I'm sorry to break your bubble if that's what you think. Just take care of yourself, do the right thing, and this too shall pass. And if you're stuck at home, enjoy time with your family. You may not get that time again. Take care.
Thank you, buddy. God bless.
Take care.
Thank you so
Bye,
much,
Shilpa.
sir, for such an insightful session and for your time.
Absolutely. My only regret is I didn't get to trouble Rachna. I enjoyed that tremendously, as Shilpa knows.
We'll do that in the group. Take care.
Yeah, Rachna is a very serious person, so it's my life goal to trouble her. But all right, take care, guys.
Thank you so much, sir.
Thank you.
Over to you, ma'am.
I would like to thank Dr. Badlani for being here and helping us look at breast cancer from a social and psychological perspective. We are so grateful to have been granted this opportunity to conduct this webinar on breast cancer awareness. I extend our deepest gratitude towards the guest speakers who made time to raise awareness around and sensitizing about this issue. Dr. Vikas Talreja, Dr. Rachna Rahotgi, Dr. Sameer Badlani, it was truly an honor to have you all with us today. I thank the audience for their interaction and participation and eagerness to learn more about the sensitive issue of breast cancer. I would like to extend my deep gratitude towards the management of WIPS, who gave us this brilliant opportunity to raise awareness about such a significant topic and provided us with all possible support to the successful conduct of this webinar. I am immensely thankful to Professor Shilpa Khatri-Babbar for being a constant support and providing her meaningful guidance throughout this campaign. Ma'am, this webinar and this campaign would not have been possible without you. I thank my colleagues, Dr. Sunil Mishra and Dr. Anshu Gagal, for their help and support. And lastly, but not the least, I would like to thank this brilliant team of NSS and Gender Champions Club who work together day and night and make this webinar possible. Thank you, dear students. Much love.
Thank you so much, ma'am.
So,
ma'am, with your permission.
I have stopped the live screening, and thank you guys. It went off really well. And whatever glitches, we work only before that. When event runs, that's the time when ownership is collective. Kisi se ek se kuch chhutta hai, the other one picks up, and that's how it's always been, like a family. But indeed, it went off very well. I mean, I'm sure would Dr. Vikas also have been in a position, it would have been like, what do you say, a cherry on the cake, but it was a brilliant thing. And thank you all of you for working so late, and especially to Tehzeeb. She's been like there since morning and had to just grab a bite, and that also a sandwich. So your kebabs are due. We'll go to Lucknow together and we'll do that.
Sure.
So, okay, God bless you guys. Maybe take a leave now.
Yes, ma'am.
Thank you so much, ma'am.
God bless you. Take rest, beta. Report and recording 48 hours. So Sunday night. Sorry. Sunday night, tak please, because once we delay, it just goes off. And Supreet, that's my fault, only because when I saw Dr. Vikas leaving and Dr. Rachna wanting to leave, so I knew this would happen. So therefore, I took the liberty of walking in Tehzeeb's vote of thanks and letting you in, because I understand that she is at a maturer level and you worked for it. So that's why. So it's from Tehzeeb and me. Thank you very much, Supreet, and apologies.
Thank you, ma'am.
Right? And we love the poem, Supreet. Thank you for writing it.
Thank you, ma'am. Thank you so much.
Bye-bye, bacha. Good night. Take care.
Thank you, ma'am.